Welcome to the Medical Report. We have a topic today which I think will be of great interest and a rather common problem in our community, namely chronic low back pain. To discuss this with you today is Dr. Matthew Schaeffer. Dr. Schaeffer is a member of the Chester County Orthopedic Associates. He is a board certified in physical medicine and rehabilitation. Dr. Schaeffer is a local person who went to Episcopal Academy. Following that, he entered Emory and then came back to go to Templeton Medical School. He did his training in physical medicine and rehabilitation at Stanford University and was an outstanding, apparently received an award for being an outstanding physician during that training program. Following his residency, he did some special training and skills for spinal cord injured patients. And he spent 4 years at a very prestigious area, Mount Tom Spine Center in Marin, California, and then came back to Reading in the Neck and Spine Center. He apparently had some chronic low back pain, or acute low back pain as a youngster with the chronic problems, and has developed an interest in that associated with sports as well. So he is certified in not only the American Board of Physical Medicine and Rehabilitation, but also by the American Board of Diagnostic Medicine. And this particular specialty is a specialty where the electricity of the muscle and the nerve is measured by certain components, and is a very diagnostic tool that many of you may be familiar with. He's a very active member in the International Spinal Intervention Society and has lectured extensively on this. So I think we have someone here today who has a great deal of familiarity with the problem. He has been in practice for 10 years, so even though he doesn't look it, he has been. So welcome, and we're looking forward to your discussion. Could you define for our audience exactly what one means by chronic low back pain?
Well, I'd be happy to, Dr. McCabe, and thank you for having me here, and I appreciate the opportunity to talk, and I think that some of the viewers have met me before in my office in Westchester with Chester County Orthopedics. So the topic is chronic low back pain today. And what chronic low back pain is back pain that has lasted longer than 3 months. This is how we define it clinically. Some research protocols require the back pain to be present for longer than 6 months. But for most of us, after 3 months, we would consider it chronic. This is not the back pain where you reach over and strain your back gardening or overdo it in a sporting event and you have a mild to moderate discomfort. What we're talking about is pain that's persisted. We're talking about that gnawing, aching pain that is like a companion with you sometimes through life, a companion that you'd like to really ditch.
So if someone has this now for 3 months or so, what are some of the causes of chronic low back pain?
Well, I think to get into the most common causes, I'd like to talk a little bit about anatomy first. Okay. Because most of chronic low back pain has its origin in the spine, not the surrounding muscles of the back, but the spine itself. And what we have here is a model of the spine. And this model shows us the base of our spine, which is called the sacrum. And then we're looking, by the way, posteriorly, or at the backside of the spine. And so we have the sacrum on the bottom, and then above the sacrum, we have joints. And these joints are called facet joints, or Z joints, for zygapophyseal joints. The common term is really a facet joint, and it's easier to understand and remember. But a joint is where two bone meets, okay? And these joints are true joints. They're called diarthrodial joints, just like your knee. They have two bones, and they have cartilage in between. They have a capsule around them, and they contain some fluid. And these joints are used so that we can bend forward and backwards. And the joints extend all the way up our lumbar spine. I'll also just mention some names of these other structures in the back of our spine. We refer to these as spinous processes, and these are part of the posterior elements. And we refer to these wide bones here as the lamina. If we turn the spine to the side, up front, we can see that it's really made up of bones stacked on one another. And these bones are called vertebrae. And we label them L1, L2, L3, L4, and L5. And in between the bones, we have cushions in our spine. And we call these cushions discs. The discs are made up of two parts. The inside of the disc is called the nucleus. It's like Jell-O. You can put your finger in it and wiggle it around. And the outside of the disc is really what's holding the Jell-O in. It's a thicker, more tensile, collagenous structure called the annulus. So we have discs, we have vertebra, or the bones stacked on one another. And then if we turn the spine on its side, we see that we have these holes. And these holes are called neural foramen. Now, out the holes, we can see these yellow things. And these are depicting nerves. So out each foramen or hole, we have the spinal nerves. Now, these spinal nerves form bigger nerves that supply your back, your buttocks, and down your legs. Without these nerves, you wouldn't be able to lift your foot up and walk. Without these nerves, you wouldn't be able to feel when you're walking on gravel. So we have spinal nerves on the side. In the back, we have these facet joints. At the base, we have the sacrum. Now, this model does not have the pelvis attached to it, but that would sit right here where my hand is. And in fact, there's a big joint between the sacrum and the iliac bone of the pelvis, and we call this joint the sacroiliac joint. This can be a common cause of pain as well. Now that we understand about some of the spinal anatomy, I'd like to answer the question about the common causes of chronic back pain. I'd like to use this poster up here. In this poster, for orientation, this is a side view, or what's called a sagittal section, a cut through the spine. And we can see the sacrum at the bottom. The buttocks, for orientation, is back here. The front of the person is up here, so the belly would be on this side. But this is the sacrum. And we have the bones or vertebrae stacked on one another. And in between these bones here and the spinous process, or posterior elements here, we have the spinal canal. And the yellow structure is depicting the spinal cord and or spinal nerves. Now, this artist rendition shows cracks in the bone, and these are depicting osteoporotic compression fractures. So some of chronic back pain can be from actually fractures of the bone. If we go a little bit lower, the artist has drawn a nice disc here, and it's shown a big crack in the disc. And we call this an annular tear, or a tear in the disc. This also causes chronic back pain. If we look just towards Dr. McCabe, we can see that the disc is protruded out or extruded out. These are words that we use to designate a disc herniation. And this is another common cause of chronic back pain. If we look a little bit more carefully, I don't know if you can see this on the camera up here, if we could zoom in on this right here, but this is depicting a little bony protuberance off the vertebrae. We call this spondylosis, but this bony protuberance can stick into the spinal nerve and compress a nerve and cause chronic back pain. This is a common thing that happens in degenerative spine disease, which is common in patients older than 70 years old. If we go back to this model, I want to show another common cause of low back pain. It's these joints. If you look at these little tiny facet joints here, you have to understand that these joints are carrying the majority of our weight every day. In fact, some research studies have shown that 40% of chronic low back pain in patients older than 55 is really coming from these facet joints. And that comes from Nikolai Bogdug, one of our most illustrious researchers in our field. So these little joints, what happens is they break down, they get degenerative, and they start to hurt. Just like in the knee, when we lose our cartilage in our knee, it starts to rub bone on bone, and it builds up inflammation and then pain, and sometimes the knee swells up. The same thing happens in these little joints. That is called facet joint pain or facetogenic back pain. Staying on the model and on the joint theme, this other big joint right here, the sacroiliac joint, this is thought to cause 10 to 15% of chronic back pain. And so joint pain is a large cause of chronic back pain. I'd like to switch gears a little bit and talk about the disc, which I think is often considered to be the most well-known cause of back pain. When people have chronic back pain, you commonly hear them say, "My disc is out." And what they're really saying or what they really think that is happening is that the disc has herniated or extruded. And on this model, we see this red blob. And what that's depicting is the nucleus of the disc, the inside of the disc, squirts through the annulus and then chemically irritates or presses on a nerve. And it really can cause pain in a number of ways. Just the tearing of the outside of the disc can cause pain in and of itself. The outside of the disc is innervated by a little nerve called the sinovertebral nerve. And so just having a tear, not even a big disc herniation pressing on a nerve, just that tear itself can cause chronic back pain. Now, if the disc or the nucleus material herniates all the way through the tear and bulges out like this, it lights, in effect, a chemical fire. Yeah, it's a big irritant to the surrounding tissues, the nerves, the soft tissues, the muscles, and it causes quite severe pain. When it herniates out, that's often that sharp, stabbing, knife-like pain. And then as the chemicals irritate the nerves, we get into more burning or aching, constant discomfort. I want you to think of the disc herniation or discogenic pain as two parts. The first part is that chemical fire there, and then the second part is a mechanical compression of the nerve or a mechanical narrowing of the spinal canal. I wanted to back up for a second and talk a little bit more about the spinal anatomy to add another cause of chronic low back pain, and that cause would be from spinal stenosis. And the word stenosis is just a Greek word that means narrowing of a canal. And so what happens is we have narrowing of this spinal canal. And this is the spinal canal, or the space that runs from the top of our head all the way down to the sacrum. And I want you to notice that there's many different holes or access to the space. Between this lamina and this lamina, we call it the interlaminar space, or this lamina, the interlaminar space. The hole or foramen on the side we call the transforaminal space. And this is another way to access that spinal space. Way down at the base of the spine, we have these other holes. And these holes are called sacral foramen. And it might be hard to see, but there's actually a big hole right here called the sacral hiatus. And so if we have spinal stenosis, or narrowing of the canal, where these nerves are trying to exit, that is a common cause of chronic low back pain.
Well, this has been a terrific anatomy course, and I think I'm pretty sure it was clear enough for everybody to understand it. So we're going to take a break for the moment, and when we come back, we're going to talk about a little bit of the diagnostic studies that you might want to do in preparation for some of the newer therapeutic efforts that you have for this particular disorder. So stay tuned, and we'll be back shortly.
Thank you.
Report. For those who are just tuning in, we have today Dr. Matthew Schaeffer, who is a board-certified rehabilitation and physical medicine physician who specializes in low back pain. And he has gone through the first session explaining the anatomy of the low back and some of the parts of the back that can cause some trouble. So what we're going to talk about first in this session is some of the diagnostic studies that might be done in order to help him decide which therapy might be best for the individual. So, Dr. Schaeffer, can you proceed with the workup?
Certainly, Dr. McCabe, thank you. So many of you, I'm sure, have experienced low back pain at one point, and some of you maybe the chronic low back pain. And when you see the physician in the office, the first study they usually go for, the first diagnostic tool we want to see is the X-ray. And the reason we go with the X-ray is because we get a good idea of the bones. We can see if there's any fractures in the vertebrae or the bones of the spine. We can see if there's arthritis in the lower joints or facet joints of the spine. We can see if there's a slip, if one bone has slipped in front of the other. What we can't see is the soft tissues. X-ray only images bones, not the discs or the nerves or the muscles. So if we have an X-ray and we're not certain the cause of the chronic low back pain, nowadays we jump rather quickly to the MRI, which is magnetic resonance imaging. And this is a diagnostic tool that gives us a picture without exposing the patient to any X-ray radiation. In fact, it's just a big magnet. It's pretty amazing. And the MRI is very helpful in looking at the discs and determining if there's a tear in the disc or a herniated disc. It's helpful in determining if there's a nerve being compressed, or if the entire or part of the spinal canal is narrowed. And that word for that is stenotic, or spinal stenosis. So the MRI is really instrumental in figuring out the cause of the disorder that's causing chronic back pain. Now, MRI has come a long way in its, about 30 to 35 years existent. It really came out in the early 1980s, and since that time the images have gotten sharper and better, and we've had to rely less on some other diagnostic tools that we used to use, which are a little bit more uncomfortable. And one of those studies is called myelography, and that's where the physician would take a needle and place it in the epidural space and inject, or actually place it below the epidural space and inject a contrast into the spinal canal. And by looking at where that contrast flows, we can determine if the canal is stenotic, if nerves are getting pinched, if there's discs pressing on the structures. Excuse me. So most of the time we don't have to do that study anymore, but in certain circumstances, such as after having multiple back surgeries, we still may need to do that myelography study. Many of you have heard of the CAT scan, and the CAT scan is another diagnostic tool that we commonly use. With the improvements in MRI, most of the time we'll only order a CAT scan if the patient has a pacemaker or cannot have MRI because of having small metal fragments near structures that we don't want the metal to move and touch. Other reasons why we use a CAT scan is if we're suspecting that there's a abdominal or pelvic soft tissue cause of chronic low back pain, such as having kidney stones or gallbladder issues or gynecologic problems. The CAT scan is often used to image those structures. In addition to the X-rays, MRI, CAT scans, which are really pictures of the spine, once in a while we'll have to use a really sensitive study called a nuclear bone scan. And a nuclear bone scan is a study in which we inject contrast into the arterial system, and if there's any abnormality or active abnormality in the bones of the spine, the contrast will be taken up by those bones, and it will emit a signal that we can pick up on an X-ray. And this is how sometimes we find those really small fractures or really small lesions or tumors in the spine. So that's the nuclear bone scan, which we do order on occasion. Now, those diagnostic tools are pictures of the spine, and they don't show pain or inflammation, and they don't show nerve injury or irritation. One of the other common diagnostic tools that we use is called electrodiagnostic studies. And in short, you may have heard of them as the acronym EMG, which stands for electromyography. What we do in this study is we stimulate nerves in one location, and then we pick up the signal in another location. And we know, during this portion of the study, we know that nerves are supposed to work or activate or conduct electricity in a certain manner, at a certain conduction velocity and in a certain time. And it's helpful to determine if the nerve is injured. It will slow down or, in some cases, speed up. The other portion of the electrodiagnostic workup is truly the electromyography, which is a needle study where we put electrodes in various muscles in the back, buttocks, and legs, and if the nerves that are supplying those muscles are not functioning correctly, the needle or electrode will tell us so. I like to think of the electrodiagnostic study as in this manner, and this is how I describe it to my patients. If the MRI or X-ray is a picture, it's like taking a picture of a telephone, and the electrodiagnostic evaluation can tell us if that phone is ringing or not. The pictures cannot tell us that. So those are some of the common diagnostic tools that we use in determining the cause of chronic back pain. And I don't want to forget to mention the most important diagnostic tool, which is simply just taking a good history, listening to the patient, and then performing a thorough examination. The history and physical examination are really the most important tools. The diagnostic imaging and electrodiagnostic studies are just an extension of our history physical examination.
And the old adage is, listen to the patient, they're telling you what's wrong. So that's what he means by giving a good history, and we depend a lot on what is said. Given the diagnostic studies, and of course there's a variety of things that you might run into, obviously people want to avoid surgical procedures, and there are currently some very minimally invasive diagnostic and therapeutic procedures that can be done. Can you kind of approach this patient from that point of view? I'm not going to this OR, I don't want it. What can you do for me?
Well, I'm glad you asked me that, because that really is my specialty, that's my field. My goal as a physiatrist is to try to decrease or get rid of your symptoms without surgery. And the most powerful tools that I use are performed in a suite where we have a machine called fluoroscopy, which is a live X-ray. and we call these minimally invasive spine injections. And we call them minimally invasive because there's no cutting, there's no surgery. We just use small needles. And we use these needles to both diagnose the cause of pain and treat it, sometimes at the same time. Let me be more specific. I mentioned earlier in our first section that the small joints in our spine, the facet joints here, cause 40% of chronic low back pain. And most of the time it's due to arthritis or degenerative changes in these joints. So what we do is we bring a patient into our surgical suite, and under live x-ray, after we give the patient what I call happy juice to make it not hurt, we numb up the skin, and I place a needle in the joint, and I inject numbing medicine in the joint, and then an intermediate to long-acting steroid in the joint. And most of the time our research tells us, and our physical exam also tells us, that the pain is elicited from the bottom two joints. Sometimes on the left side, sometimes on the right side, but nonetheless, it's from these joints. And if we inject a mediator of inflammation, we can stop these joints from hurting. So that's one of the procedures that I use to both diagnose and treat chronic spine pain. We'll stay on the joint cause of back pain for a moment. And I mentioned that there's a big joint called the sacroiliac joint, or SI joint, and we do the same thing with this joint. This joint can become hypermobile and cause pain. I take a needle under live x-ray, I numb up the skin and then the joint so it does not hurt, and I inject intermediate to long-acting steroids in the joints, which should stop it from hurting for an extended period of time.
By
Now,
steroids, you mean cortisone products, right?
Cortisone products, yes.
All right.
Yeah. And we find that if we can stop these joints from hurting, then we can train the patient on how to avoid aggravating these joints. And often this is done with the help of physical therapy. And we train the patient how to unload the joints. Now, another procedure that we commonly do is the epidural injection. And in fact, there's not just one type of epidural injection, there's many different types. If we come back to the model, we have these spaces between the bones in the back, and this space is called the interlaminar space. And the old-fashioned way of doing an epidural injection would be to bend the patient over and put a needle in here and inject numbing medicine and steroids. Some of you probably have had that procedure, and remember that it can be a little bit uncomfortable. So over the past 20 years, we've developed a much safer, more comfortable, and a more efficacious epidural. And that is, we take a needle into the side holes. And these holes, again, are called neural foramen. And the reason why this is safer and more efficacious is because it's right where our problem is. Most of the time, the problem is from the disc or the nerve. So what we can do is we can, under live x-ray, which makes it safer than the old-fashioned epidural because we can see what we're doing, I take a needle and I put it right here, and I inject numbing medicine again so it does not hurt, and then I inject the cortisone-type medication on top of the nerve that's irritated or around the disc that's causing the pain. And this type of epidural is called a selective fluoroscopic guided transforaminal epidural. But in short, you can just say, yes, I had an epidural and it helped me. In the same region, we have these nerve roots. And sometimes the nerve roots themselves can be the source of pain. And in that case, we do what's called a selective nerve root block, which differs from the epidural just by about 1 centimeter. We move the needle over and we just inject the numbing medicine so it won't hurt, and then steroid medication on top of the nerve root. And it's a depot steroid. It's a steroid that's going to sit there in a powder-type form and prevent that nerve from irritating the surrounding tissues or sending signals up to the brain that says, owie, I have pain.
Well, this is an excellent description of what can be done without any major procedure. And I think maybe the viewers would like to know what the results are percentage-wise for this sort of thing.
Right. Well, using the minimally invasive spine approach, we get the majority, we improve the majority of our patients' pain. In fact, Johns Hopkins published a nice study about a year and a half ago, and they had 5,000 patients, or over 5,000 patients in this study. I think we looked, yeah, over 5,000 patients. And these were patients that had severe back pain associated with a disc herniation. Let me move this model over and show you. So these patients all had single-level disc herniations like this, irritating a nerve root and causing back pain and most of the time leg pain. Half the patients, they said, why don't you go and have surgery? Have a surgeon remove this disc herniation. And in fact, at the 12-month period of time, they had 90% success rate. So at 12 months, 90% of the patients said, that went great, I'm glad I had the surgery. Well, the other group, we had them do non-operative management, which is what I do, these minimally invasive injections. And on average, these patients had 2 of these epidurals and 3 months of physical therapy, and they had 90% success rate. At 12 months, 90% said, I feel great, I'm glad I did not have surgery, thank you.
Well, that is terrific, and we certainly do appreciate your discussion today. This has been a very different approach, so we thank you, and I hope we can have you back again. There's more to say about back pain, I'm sure.
I'd be happy to. Thanks, Dr. McKay.
You're quite welcome. Thank you for watching. Stay tuned to keep informed.